Dear Marrowlings, welcome to this video where we are talking about Psychiatry INI-CET November 2022. In November 2022 INI-CET, we had two sessions, right? The morning and the evening session. The morning session had questions in relation to conversion dissociative disorder, impulse control disorders, question on lithium, and alcohol withdrawal. Now, alcohol withdrawal is something which has been constantly asked almost every single year, right? In the session 2, we had nicotine cessation, which is again quite commonly asked in the recent years. A definition of stress was asked, which many times needed logic for you to apply. Antipsychotics mechanism of action, and SSRIs and pregnancy risk was something which was kind of discussed in session 2. Now, let's jump into the MCQs for us to understand better. Taking up the question in session 1, and these are recall questions, so sometimes some of the choices or the question framing could be a little different, but we have tried to keep it as authentic and as replicable as the main exam. So, taking up the first question, a 14-year-old girl presented with kind of a sudden onset of blindness, which is a sensory complaint. And it also says, the question says the person is not concerned about it and physical examination has turned out to be normal. And when you take history, you also get to know that recently they lost the mother and they are feeling guilty that they have not spent enough time with mother, some kind of a social stress. So the choices given were based on whether it happens in adults, whether it happens on males or females commonly, or in children, or males and females commonly. Now, in a question like this, in any clinical scenario, we need to look at the keywords, right? What kind of keywords come up in the first shot? A 14-year-old girl with a sudden onset of blindness for about past 4 hours. So something like a acute cerebrovascular accident should have happened, some kind of a trauma should have happened, which could have made people present with this. Not only this, here in the background, you also get to know what? You get to know that she also is concerned about a few things. One is mother passing away and she feels that she should have spent a lot of time. If you look at a very important point, the physical examination has turned out to be normal and she isn't concerned with the symptoms which she has developed. She isn't concerned about the symptoms which she has developed. Looking at these key points, what is the diagnosis you would like to make? The obvious diagnosis which should come to your mind is conversion disorder. What is conversion disorder, by the way? Now, conversion disorder is type of a dissociative disorder. In DSM-5, the latest term for conversion disorder is functional neurological symptom disorder. ICD-11 calls it as dissociative neurological symptom disorder. If you look at both these names, what is the most common term? Neurological symptom. So basically, conversion disorder is nothing but a neurological presentation which cannot be explained by anatomy and physiological processes, and most of the times it happens in the context of some kind of a psychosocial stressor. And most of the times they are acute onset presentations, most of the times. One of the key words, if you have listened to the video on conversion disorder, I would have described is la belle indifference. What is la belle indifference? In this question, it was said, right? The person is not concerned about the symptom. That is called as la belle indifference. Means what? The patient has such severe symptoms, but the emotional concern about it is not much. That is what is called as la belle indifference, and it is characteristic of conversion disorder or dissociative disorder. Another term also has been asked in exams. What is the other term you should know? Astasia erbasia. What is astasia erbasia? Very good. Bizarre abnormal gait presentation, right? Bizarre abnormal gait presentation, which cannot be explained by any of the neurological conditions which exist. So that kind of presentation is called as astasia erbasia. These are terms which you should know can happen in conversion disorder, which is nothing but a type of dissociative disorder. Now, one interesting controversial point you need to know is conversion disorder is a type of dissociative disorder as per ICD, whereas in DSM, it is a type of somatic symptom disorder. That's one difference you should know. Conversion disorder is a type of somatic symptom disorder in DSM-5, whereas conversion disorder is a type of dissociative disorder in ICD-11. With this understanding, when you're talking about conversion disorder, what you should know, conversion disorder is basically a defense mechanism. It's a way our ego tries to defend its own self when there is some kind of a stressful point. So it's a kind of defense mechanism. Most of the times, conversion disorder typically presents in individuals who are less than 35 years of age. It can be seen in children and adolescents and young adults very, very commonly. Now, who presents more commonly? Female gender is about 2 to 3 times more commoner presentation. With this understanding of all these points, going back to this question, what do you think is the best answer? The best answer here is in children occurs more in females than males. Now, actually, it not necessarily occurs in children. It can happen less than 35 years of age. Anybody who is growing up, who doesn't have adaptive coping strategies and healthy coping strategies can get into conversion disorder kind of presentation is what you need to understand. So, this is the choice we can go here because that's the only one which is given more in females, and conversion disorder is seen more in females is what you need to remember. Going to the next interesting question, a simple question most of you can easily answer is they've given a few impulse control conditions: kleptomania, pyromania, mutilomania, and dipsomania. Now, what is the right choice? You have to match it. Now, I'm sure most of you would easily know kleptomania is nothing but an intense desire to steal items of trivial value, paper clips, some stationery, and those kind of things, right? That's kleptomania. They steal things without many purpose and reason. They might many times steal and keep it at home and not even pick it up and use it. So that's what is typical of kleptomania. They might not be able to stop the urge once the urge kicks in. So that's kleptomania which happens. It leads them to many times police arrest, legal cases, and getting into embarrassing scenarios many a times. What about pyromania? Now, when you're talking about pyromania, it's an intense desire to fire setting and burn things. Now, pyromania is also an interesting point you need to remember is as children growing up, if they have fire setting behavior, if they have the behavior of fire setting, it is a part of what we call as McDonald's triad. What is McDonald's triad? The McDonald's triad includes fire setting, enuresis, and that is bedwetting, and animal cruelty. This McDonald's triad is a triad of features which is seen to predict future violent behaviors or sometimes even criminal behavior. So, history of bedwetting, fire setting, and animal cruelty is the triad called as McDonald's triad, where you should also remember the term pyromania, which is an intense desire to burn things. Mutilomania is an intense desire to mutilate or kind of destroy the insects and those things. That's called as mutilomania. And dipsomania is quite commonly seen clinically, where people have habit of binge drinking and excessive drinking of alcohol. That is what is called as dipsomania. As we are talking about impulse control conditions, a few more terms have come quite commonly in exam: satyriasis, nymphomania, and oniomania. What is satyriasis? Increased sexual desire in males is called as satyriasis. Increased sexual desire in females is called as nymphomania. What is the word oniomania? Oniomania is nothing but your compulsive shopping. With all the online resources which are available at the click of a button in your mobile, oniomania is something which we do see quite increasing, and compulsive shopping is quite a challenge these days. That's one of the impulse control conditions which can happen. Moving to the next interesting question. What is the dose range of lithium in milliequivalents per liter for acute attacks of mania and long-term maintenance? Now, the ranges which were given were 0.1 to 0.5, 0.6 to 1.5, 1.5 to 2.0, and 2 to 3. Now, anybody who has listened to the videos in psychiatry would have easily answered this question because we have spoken about these things, right? So, lithium is one substance which we should know when you're preparing for exams because it's a gold standard thymoleptic. What is thymoleptic? It's an old term for mood stabilizer. And why should you know about lithium specifically? It has a narrow therapeutic index, and because it has a narrow therapeutic index, when it goes less than 0.5, it is ineffective. When it goes beyond 1.5, it has lithium toxicity. So the broad range is anywhere between 0.5 to 1.5 milliequivalents per liter. So with this understanding, you know what is the answer for this question? What is the answer for this question? It is choice B, that is 0.6 to 1.5 milliequivalents per liter is the best choice we can can think of. Now, since we are talking about therapeutic range, it is also important to know that lithium is one drug where we would like to do blood test, right? We would like to know the serum lithium levels, right? So when we start lithium, they've asked this interesting question also. When do you check for the serum lithium levels? The first day, second day, third day, when? We should give at least 5 half-lives. 24 hours is the half-life of lithium. So at least 5 days should go by. After taking medicine for 5 days regularly, then only you get the serum lithium levels done. It is generally done 10 to 12 hours after the last dose. 10 to 12 hours after the last dose is the time when you should actually kind of check the lithium. What we always instruct our patients is they should have been taking the medicine regularly for at least the last 5 days before they do the test. And if they're taking medicine at night 9 o'clock, morning 9 o'clock, between 7 and 9 o'clock in the morning, that is 10 to 12 hours from the last dose, they should go ahead and get the blood test done for us to know the exact serum lithium levels, for us to decide whether it is in the therapeutic range. And please understand, earlier they used to say acute levels are different, maintenance levels are different. But nowadays, studies say in acute as well as in maintenance phase, it is good to maintain the same lithium levels. Whatever is effective in the patient, we need to maintain. And most of the times, the level is between 0.6 to 1.5 milliequivalents per liter. The best effect will be when it is nearest to 1.0 milliequivalents per liter for the best effect. Understood? Next question. A patient who is chronic alcoholic has history of seizures and altered sensorium. He has been drinking for the past 10 years and takes 24 units per day. His last drink was about 2 days back. He is found to have auditory hallucinations, secondary delusions. How will you manage this patient? Now, they have given too much of data to just confuse you, but it's a pretty simple answer. Okay. Diazepam, thiamine, naltrexone, flupentixol, depot preparation. What would you like to give? Which combinations do you like to use? All of them? Which of them can be used is the question. To dissect it further, you need to know the key words given here. What are the key words? A chronic alcoholic, presents with seizures and altered sensorium. There is altered sensorium, that is delirium tremens has set in. The person is also having auditory hallucinations, and the last drink was about 2 days back. We know seizures generally happen within about 2 days, and most of the times post seizures, they might end up into some kind of confusion or delirium process can kick in. So we are talking about in this question about alcohol withdrawal. And when you're talking about alcohol withdrawal, it's good to know about two important things where questions come. One is the timeline and the symptoms. When you're talking about timeline and symptoms, the other one is the treatment. When you're talking about the timeline and symptoms, you need to know within 1 day of stopping alcohol, you can develop symptoms of alcohol withdrawal, that is tremors of hands, nightmares, restlessness, sleep disturbance, all those kind of things. Within 1 day of stopping alcohol, symptoms start off. Many times within 12 hours to 24 hours, it starts off. So within 2 days of stopping alcohol, they can develop seizures. Within 3 days, most of the times, they can develop delirium tremens. When you're talking about alcohol withdrawal related treatment, we all know when you've read biochemistry, whenever patients with chronic alcoholism come in, we suspect thiamine deficiency, and thiamine is extremely required for metabolism. So thiamine has to be supplemented in patients when they come in emergency room. Along with thiamine, benzodiazepines are the treatment for alcohol withdrawal. Why I'm stressing this point is because even if the patient has delusions, auditory hallucinations, altered sensorium, you can add antipsychotics if the patient is very agitated. What is the primary treatment in alcohol withdrawal? It is benzodiazepines always. So in alcohol withdrawal, if they ask you which is the must drug, benzodiazepines are the answer. Now, all benzodiazepines are equally effective, but can you choose some specific ones? You can choose LOTE. LOTE in liver dysfunction and elderly patients. In liver dysfunction and elderly patients, you can choose LOTE. What does it stand for? Lorazepam, oxazepam, temazepam, and estazolam. In this clinically, very commonly what we use is lorazepam because it is available as IV, IM or oral medication, so easy to titrate and use it. So the answer for this question is a simple choice B, which is 1 and 2 included. So with this, we come to an end of the questions of session 1. We'll go ahead and talk about the session 2 MCQs. So going to the session 2 MCQs, let's jump into the MCQ. A chronic smoker wanting to quit is treated with which of the following oral medication is the question which has been asked. Varenicline, muscarin, cevimeline and atropine. Now, a chronic smoker wanting to quit is the question. So they're talking about nicotine cessation here, right? So very simple, straightforward question. If you know about nicotine cessation, which we have discussed in the video, you would easily answer this. So what are we talking about? In nicotine cessation, we can talk about nicotine supplementation or we can talk about anti-craving kind of medications. So when you're talking about nicotine supplementation, we have the gums, lozenges or the patches. The gums and lozenges are generally available as a 4 mg or a 2 mg gum and lozenges. Whereas when you're talking about patches, we are talking about a 21 mg patch or a 14 mg patch or a 7 mg patch which is available. So 21 mg per day or a 14 mg per day or a 7 mg per day patch is available which you can use. When you're talking about the anti-craving medications, the two important anti-craving medications we have is varenicline and bupropion. These are the first line kind of drugs. In this, varenicline is one of the most effective tobacco cessation strategies which we have. Bupropion is the next best. Now, other second line anti-craving drugs are also available. Which are the second line anti-craving drugs we have? The clonidine, nortriptyline, naltrexone. One of the interesting questions which came in the last year exam was they're given bupropion, varenicline, they had also given clonidine and nortriptyline or naltrexone, I guess, and they asked which of the following is the most effective drug in nicotine cessation. The answer is varenicline. And what does varenicline do? Varenicline is a alpha 4 beta 2 partial agonist. Alpha 4 beta 2 partial agonist is what is varenicline, and that's how it produces the effect of reducing the craving for nicotine. Understood? It also reduces some of the withdrawal symptoms of nicotine. Mostly importantly, it reduces the craving for nicotine, thereby increasing the chances of tobacco cessation. So answer for this question is what? Varenicline is the answer for this question. Going to the next interesting question. Which of the following characteristic is true about stress? So there's a lot of confusion about the recall of this question. So with kind of what we got, we have made a consensus of it. There were choices like impending doom, constant worry about negative consequences, preoccupation about illness, an emotional, cognitive, physiological, or an autonomic response. Which of the following is true about stress? Now, interesting question because it's good to know impending doom can be seen in many scenarios, right? But where is it very characteristic? It is characteristic of panic attacks. Where do you see constant worry about negative consequences? Generalized anxiety disorder patients typically have such kind of symptoms. Where do you see a preoccupation about illness? It is seen in illness anxiety disorder or hypochondriasis, right? In illness anxiety disorder, hypochondriasis, people are preoccupied about having some kind of an illness. With this understanding, you automatically know what is the answer for this question. The answer for this question is stress is something like an emotional, cognitive, physiological, autonomic kind of a response. Now, stress is such a common term we all keep using left, right, and center. But what does stress in simple terms mean? Now, World Health Organization says stress is nothing but a body's response. Now, response to what? Body's response to something which needs you to take action or it needs you to attend to it. Anything which needs you to attend to or which needs you to take action, the body's reaction and the response is called as stress. Now, this body's response most of the times in stress is transient. It kind of comes and goes until unless we are dealing with some kind of a chronic stress, right? It's transient. And what does this body's response look at? It can be an emotional response. It can be a physiological response. It can be a psychological response. It can be emotional, something related to feelings. It can be physiological, something related to the physical body. And psychological, it can be something related to the aspects of mind. Now, as part of this response, autonomic system is activated many times. And that is one of the reasons when we are stressed, we do see palpitations, increased sweating, sweaty palms and those things, right? That autonomic arousal is a very typical feature of this stressful reaction. So basically, when you're talking about stress, we are talking about a body's reaction to something which needs you to give attention or needs you to act. and it is mostly transient. It's kind of an emotional response, physiological response, or a psychological response, which also includes the autonomic system activation, which happens as a part of this body's response. Now, is stress good or bad? Most of the times it is transient, it comes and goes, but it also depends on how long the stress remains and how severe it remains, and how do we handle the stress? How do we attend to it, or how do we act on it? If we deal with it in a sensible way, things do get better. Otherwise, it can lead to consequences and challenges. So that's something which you should know. Recently, we have seen questions on burnout also being asked, so I thought I'll highlight it here. Burnout is something similar to stress, another common word which we use. What is this burnout all about? Easy to remember acronym DIE, DIE, DIE. What does it stand for? A person who is in burnout typically has a detached feeling. They have a detached feeling. They feel very detached from the work. They would have been very passionate about it. Now they become very detached. They feel what big deal kind of a thing. And they also feel ineffectiveness of the work. They feel what they are doing doesn't make much difference. They feel somebody else can easily replace them and do better job and those things. They feel very ineffective. They feel detached. They feel very ineffective, and extremely important, they feel exhaustion, mental exhaustion, physical exhaustion. So if you're going through a lot of detached feelings, a lot of ineffective feelings, and you're also going through a lot of exhaustion, you need to ask yourself, are you going through burnout? Now, we are all many a times as doctors choosing the profession by choice, right? We want to become doctors, we want to save the community, we need to help people and those kind of stuff. So a lot of times our passion goes on, and sometimes we end up overworking and getting into burnout. And burnout is typically described in occupational environment, okay? We don't talk about burnout in other areas until unless we are talking about in occupational environment. So what does it stand for? DIE, detached feelings, ineffectiveness, and exhaustion are very characteristic features of burnout. This is also something which was asked last year, so might be tested again, so good to know. So going to the next question, which of the following statement is false about disulfiram? Now, there are various choices given. It inhibits the alcohol dehydrogenases, accumulates the acetaldehyde, initiated at 250 mg, and not an anti-craving agent. If you've read about disulfiram, which is an important drug for you to know when you're preparing for exams, is disulfiram. You need to know it is not an anti-craving agent. It is an aversive drug. And it is an aversive drug which is generally started after 12 to 24 hours of the last drink. We start this drug when the patient is willing to take it, and once they give consent, once they know the consequences which can happen if they drink, then once the consent is received, we start after 12 to 24 hours of the last drink. Generally, we started at a 250 mg dosage is what we need to understand. Earlier, people used to give much higher dosages, but these days, 250 mg is what we most of the time start off. It is an irreversible aldehyde dehydrogenase inhibitor, and it leads to accumulation of acetaldehyde. It leads to accumulation of acetaldehyde because it's an irreversible aldehyde dehydrogenase inhibitor. So with this understanding, you automatically know what's the answer for this question. It is the choice A. It is not alcohol dehydrogenase, it is aldehyde dehydrogenase inhibition, which is done by disulfiram. Thereby, it increases the acetaldehyde levels, thereby leading to the disulfiram ethanol reaction. An important point for us to know, which has been tested multiple times in the exam. So, going to the next interesting question. Which of the following antipsychotics related mechanism is not correctly matched? They've given some antipsychotic related mechanism and they've asked which is not correctly matched. They've given anticholinergic blockade reduces extrapyramidal symptoms caused by antipsychotics. D2 blockade in the mesolimbic pathway reduces positive symptoms. 5-HT2A blockade influences negative symptoms. 5-HT1A blockade influences weight loss and kind of positive symptoms. Now, they're talking about antipsychotic related mechanisms. We have discussed about antipsychotics and how does it function in video related to antipsychotic medications. But you need to know here, for this question, very simple point. When you're talking about antipsychotics, you have the first generation antipsychotics and you have the second generation antipsychotic, right? predominantly, most of the antipsychotics do one thing. What do? They decrease the dopamine neurotransmission in some way or the other. So they decrease the dopamine neurotransmission in some way or the other. That's how they produce the antipsychotic effect. Both the first generation and the second generation. But the first generation or the typical antipsychotics mostly do that by D2 receptor antagonism. How do they do it? They do it by D2 receptor antagonism. So talking about the second generation antipsychotics, what is good to know is how do they work? They work on 5-HT2A antagonism. So second generation antipsychotics or the atypical antipsychotics have more affinity, more than the D2 receptors. They work a lot more on the 5-HT2A antagonism, and that is how they produce the decreased neurotransmission. Not only that, even if they block the D2 receptors, they have fast dissociation from it. By having that fast dissociation, they have lesser chances of producing extrapyramidal symptoms in the second generation. Very important point, 5-HT1A agonism is one of the methods by which decreased dopamine transmission can happen through the second generation. 5-HT1A agonism can happen. Now, this 5-HT1A agonism gives you a clue to say what is the answer for this question. In the question they have spoken about 5-HT1A blockade, whereas for you to have antipsychotic effect, generally you need 5-HT1A agonism. So the answer is choice D, which is the wrong one here. Understood? That's the answer for this question. Whereas the rest of them are correct answers. So when you're talking about the choice A, what you should also remember is anticholinergic blockade reduces extrapyramidal side effects. Is it true or not? Yes, right? Clinically, what do we do when patients have drug-induced Parkinsonian kind of symptoms? We very commonly give trihexyphenidyl, which is nothing but an anticholinergic agent, which kind of reduces the rigidity caused by the antipsychotic. So again, please remember the typical antipsychotics or the first generation antipsychotics basically works on D2 receptors and blocks that. The atypical or the second generation antipsychotics works mainly by three mechanisms, that is the 5-HT2A antagonism, fast dissociation of D2 even when they block D2, and 5-HT1A agonism. That's how the atypical or the second generation one works, and that will help you to answer questions related to this topic. Going ahead, the last question of this section 2 is this. A pregnant woman is on SSRI, and what is the risk of increased issues in the newborn? Low Apgar score, ADHD problems, persistent pulmonary hypertension, delayed developmental milestones. The choices they have given is all of them, three of them, which three, and those kind of things. So we are talking about pregnant women on SSRI and the risk of developing some of these problems. Please remember, SSRIs invariably even today remains the commonest antidepressant prescribed. Now, it is a commonest antidepressant prescribed. We do know one thing about SSRI usage. It is not a major teratogen. So if you have to give SSRI in a patient, if the patient is having significant depression and is affecting their quality of life and those, you can give SSRI. It is not supposed to be given. If at all you want to avoid, studies have shown what? Paroxetine. Studies have shown paroxetine is an SSRI which is known to cause a lot of cardiac malformations and those things. So it is preferable to avoid paroxetine at any cost. If at all you want to give, you can consider giving other SSRIs. Commonly used are sertraline and escitalopram are common ones which are prescribed. There are some studies to say fluoxetine could have its own challenges. So paroxetine is something definitely which is avoided among SSRIs. And SSRIs are not major teratogenic agents. It can be given if the patient has significant risk. Now, SSRIs can cause a few problems. What problems can it cause? It can cause low Apgar score. It can cause persistent pulmonary hypertension. It can also cause delayed developmental milestones. Now, these are all reported in various case scenarios and case studies. ADHD is something which I did not get much of studies to say, but might be. And we know ADHD being quite common with anybody who has had developmental issues. So we know maybe ADHD also could be there in these patients. Now, one of the biggest challenges we don't know is whether the patient's depression itself can lead to a confounding factor and lead to children having problems, or is it the antidepressant usage? That always remains a controversial area. So it is good to avoid giving antidepressants whenever possible, but if the risks are very high and the patient needs the antidepressant, you can consider SSRI, which sometimes can be helpful in giving better quality of life for the mother and the newborn in due course of time. So the best choice for this question is A, B, C, D. All four can happen with SSRIs. All four can happen with SSRIs. With this, we come to an end of this INI-CET November 22 discussion, session 1 and session 2. Thank you very much for your patient listening. Best wishes for your future.